So our practice injury scenario for today, we have a athletic trainer working with the SFU hockey team. It's between periods and they're walking off the ice. The coaches remain on the bench for a few minutes afterwards to discuss what's happened in that period. And you, the trainer, head to the trainer's room. And then 2 minutes later, coach comes hobbling in, supported by the two assistant coaches, working their way into the training room. So, of course, you want to know what happened. Well, the coach was walking off the ice, slipped, fell, and on the right side, the knee kind of collapsed down into hyperflexion, felt a bit of pop in the knee, and great difficulty walking. Where is the pain? Pain is on the medial side of the knee. They feel it with every step that they take, and especially if they try to bend that right knee. What makes it better? Not weight bearing basically is the only thing that makes it better at this point. What makes it worse? Squatting and flexing that right knee makes the pain quite a bit worse. Rate the pain out of 10, so they'd give it a 7 out of 10 for pain. And what is their 10 out of 10? We'll say they used to play hockey and they dislocated their shoulder. That was the worst pain that they ever felt. Prior injuries, we'll say no prior injuries to that right knee. Any snap or pop. This is an acute traumatic injury, so we need to ask that. And as we mentioned already, they did feel a bit of a pop when it happens. Medications or allergies. The team's not doing very well, so coach is on a heart medication. That's not going to affect this injury at all, and no allergies. So that's it for our history. We're not concerned about footwear because this was an acute traumatic injury. Obviously, they slipped on the ice, so the footwear they're wearing is not correct for the environment. But they're just coaching. They're not one of the players. So for our assessments, we want to start with observation. So we're able to just barely pull coach's dress pants up over their knees. The assessments, observation, and we see noticeable swelling already. So that in itself, from observation and seeing there's quite a bit of swelling, we're already thinking intercapsular knee injury. So ACL, PCL, and meniscus. And we know even before we do our ligament tests, we're going to do our intracapsular swelling tests just to confirm our suspicions. We ask them to squat. They can't squat down very low. Most of the weight is on the left leg, the non-injured side, and they need to use hands for support on the trainer's table to get down. Gait, noticeable limp when they weight bear on the right hand side. We could do tiptoes, knee to wall. They're both normal. Next, we get into our non-weight bearing assessment. So range of motion, active range of motion. For the knee, we're concerned about flexion and extension. So active knee flexion is decreased and there's moderate pain. And for extension, we'll say, flexion is decreased moderately with moderate pain, and extension is decreased mildly with mild pain. Passive range of motion, flexion still decreased moderately with moderate pain. Extension, we get full range of motion, but they have mild pain at end range. And then for resisted range of motion or strength testing, flexion is 5 out of 5 and no pain. Extension, there is some weakness, 4.5 out of 5, and they have mild pain. After our strength testing, we normally would do our ligament stress tests, but because we saw swelling, obvious swelling within the knee right away, we're going to do our intercapsular swelling tests just to confirm our suspicions that they have an intercapsular knee injury. And so our swipe test, where we take the back of our hands and swipe up the medial side of the knee and try to force that swelling away from the medial side of the knee, and then swipe down the lateral side of the knee with our back of our hand and look for that bubble of swelling to push back over to the medial side. And when we do that, we do see the bubble of swelling push over. So our swipe test is positive. And then patellar compression was our other intercapsular swelling test, where we wrap fingertips and thumb around the perimeter of the patella and push straight down. And normally it's a hard end feel, bone on bone, maybe a millimeter of movement. With swelling accumulated behind the patella, you're going to get 3 to 4 millimeters of movement, and it's going to feel soft and squishy. And in this case, that's what we find. So our patellar compression test is positive. So it confirms our suspicions that they have an intercapsular injury, and it means that we're going to focus on ACL, PCL, and meniscus. So we'll get rid of all this stuff, and then we'll just focus on those 3 intercapsular structures. Does not matter what order you test them in, because you're going to do all 3. Even so, in this individual, they have medial knee pain. You might be suspecting that it's meniscus rather than the pain feeling deep inside the knee. So intercapsular structures. ACL, we've got our anterior drawer test. Athlete lying on their back, hip flexed 40 degrees, knee flexed 90 degrees. We sit on the end of their foots and pull on the tibia towards us in line with the knee joint line. There's no increased laxity or movement on the injured side compared to the non-injured side, so that's negative. Lockman's is where their knee is flexed about 30 degrees. We've got a cushion or roll underneath their distal femur, and we trap their femur between our hand and the roll, and we wrap our other hand around the back of their tibia and pull more up towards the ceiling. Again, no increased laxity or movement on the right side compared to the left, so that's negative. PCL, we had posterior sag and posterior drawer. So posterior sag, athletes laying on their back, hip is flexed 90 degrees, knee is flexed 90 degrees, and we hold underneath their heel, and we look for gravity to move the tibia backwards, which is what the PCL tries to prevent. And we see no posterior translation of the tibia after a couple of minutes. It is negative. Posterior drawer, same setup as anterior drawer. It's just now we're trying to force the tibia posterior, and we see no translation, so it's negative. So that just leaves us with meniscus. And again, you might have started with meniscus, but even if it was positive right away, I still want you to do your ACL and PCL tests, because in the real world, they could have multiple injuries. For your injury scenario, it'll only be one of the possibilities, normally anyhow, for the in-person one. For your virtual one, because you're not getting feedback, you're going to assess for all 3 of these injuries, and you would diagnose all 3 of these as possibilities. So meniscus, we have our Apley's compression, athlete laying face down, knee flex 90 degrees. You've got your forearm on the bottom of their foot pushing downwards while you passively internally and externally rotate the tibia. And we have moderate pain and the pain is increased when we externally rotate the tibia. Remember, external rotation more tightens the internal knee joint capsule and therefore stresses more the medial meniscus. And McMurray's is where the athlete's laying on their back. We flex their knee as much as they can tolerate. And if I want to stress the medial meniscus, I'm going to externally rotate the tibia. I'm going to apply a varus stress through the knee. External rotation, varus stress through the knee, so pushing from the medial side towards the lateral side while we flex and extend the knee. So a few steps involved with McMurray's. As we do that, they get a sharp twinge of pain at a particular range of the knee flexion. Pain's on the medial side, and we can reproduce it every time we do that flexion and extension of the knee. So McMurray's is positive. Palpation. We're going to palpate along the joint line, both medial and lateral. And when we palpate along the medial joint line, they have moderate pain. It reproduces the pain that they're feeling. So our diagnosis, medial meniscus tear. So you were suspecting it as far back as your assessment and observation. When you saw that there was swelling, you suspected intracapsular structure and maybe leaning a bit more towards meniscus because the pain was more in the medial joint line rather than deep inside the knee like we might see with ACL, PCL. So you test all three structures. Again, normally for the in-person one, you'd be getting results of your test and you'd be able to narrow it down to one of the three. For your virtual injury scenario, you're not getting feedback on your test, so your diagnosis would still be all three of these possibilities. In terms of treatment, police, we're going to send the athlete to their doctor. This is not a medical emergency, but have them get in and see their doctor within a few weeks. Doctor's going to refer or suggest they go for conservative therapy, physio, because like we talked about in lecture, they're not going to do surgery on the meniscus, or certainly not right away. We want to get the swelling down. We want to increase the strength around the knee, so isometric, isotonic, eccentric strengthening, balance proprioception, running progression, or in this case for the hockey coach, have them try and resume skating and see how the knee responds to it. And more recent research suggests that conservative therapy is equal in terms of long-term satisfaction to surgery. It's only if the coach, they try to get back on skates and it's very painful and the knee is locking on them periodically when they're walking or going up and down stairs, get stuck in a certain position, then they might do surgery to remove, if they had a bucket handle tear in the meniscus or a free-floating fragment within the knee joint, then they may go in and try and remove that piece. But otherwise, like we talked about in lecture, they're trying to avoid doing surgery as much as possible. So that's it for our knee injury syndrome.